the adult brain to drugs. I've engaged in chemical design, in brain imaging, in a number of other areas in academic life, including teaching and public outreach as well. We created the first CD to explain to the public how drugs affect the brain, and the Disney Corporation licensed it. We had a museum exhibit and a play, which was a success, but nothing prepared me for a phone call one day when I received a call from White House counsel saying, if you are nominated, would you be interested in serving in the White House Office of National Drug Control Policy? Even though my primary love is to do research, Mark actually asked me to present this summary, so I'm going to do the best that I can. The process begins with a cake. In the middle of it, there's a swearing-in ceremony, and it ends with a cake. But there's nothing cake-like or a cakewalk with regard to the challenges that I faced for demand reduction, which was my portfolio, which was prevention, intervention, and treatment. In terms of the populations of children and adolescents and adults and fetuses and the elderly, the prisoners, the military, in terms of which drugs we were to pay attention to, the whole gamut, including emerging designer drugs, in terms of the consequences to children, to families, health, education, employment, safety, in terms of the cost to our society, generally dissected in terms of healthcare, criminal justice, and productivity, and the research voids that I identified along the way, whether or not our policies were accurate or not. So how to focus on these national challenges? Prevention was was from my perspective a critical issue, primarily for young developing brains, because the NISDA data has shown that young adolescents who initiate drug use at the age of 14 or younger are 5 to 6 times higher in prevalence as addicts when they become adults. And that is true for alcohol, for marijuana, for nicotine. I can go through the entire shopping list. It appears that the adolescent brain is far more fragile than the adult brain. The second challenge was intervention. Approximately 70 million people in our nation engage in risky use along a full spectrum, from no consequences to accidents to school dropouts to loss of employment, all the way to addiction. And the final challenge is treatment. More than 20 million people need treatment. And the vast majority of them, 94.6%, this is the most recent data that just came out a couple of weeks ago, the vast majority of them are unaware, do not think they need treatment, do not show up for treatment. That's over 20.6 million people. And only 1.7% of the total in need of treatment actually try to get treatment currently. Those stats have hardly changed. So the specific challenges are prevention, trying to identify the unidentified, 70 million people with risky and problematic use, trying to identify the people who need specialty treatment, the scalability, how do we develop programs? I won't get into some of the challenges there, but there's a lengthy discussion on these issues. Resistance to change with regard to implementing or introducing new programs, and also the travesty of many of the treatment programs in our country. And some of these travesties I learned by traveling to many treatment sites that were federally funded and seeing the weaknesses. So some of the specific solutions, we had a small pilot study on SBIRT screening, brief intervention, referral to treatment. SBIRT has been in the literature since 1959. A young physician at the Mass General published the first report on it with regard to alcohol. It then navigated through the globe. It went to England and a few other countries where there was some indications that it could work. Brief intervention could work with regard to smoking cessation. The literature remained flat for more than 30 to 40 years. And I looked at the data when I initially came to the office. I looked at the data on drug courts and on access to recovery, a number of programs. And in the short time that you have in the White House, because the budgets are set 2 years ahead of time, believe it or not, other than the Appropriations Committee's final decisions, but the Office of Management and Budget sets the budgets with us early, well ahead of the time that I would have there. I knew that I had to focus on a few issues. There was no way that I could handle all of them. And SBIRT popped up just because I asked for the data from SAMHSA on what the outcome measures were. And when I looked at the outcome measures, I said, this is something that we really could bring to scale. To look at cost effectiveness and effectiveness, to look at the analysis of resistance to change, that's a critical challenge, and also to look at some of the incentives that we could provide to address resistance. So we published the first report on the federal SBIRT program, in which 460,000 people were screened. Of those, these are people screened in healthcare centers, community centers, and hospital emergency departments, and inpatients in hospitals. Of the people who were screened, 22.7% screened positive for risky, problematic use or addiction. And as I said to many audiences in grand rounds and a number of other venues, if this were cancer or diabetes, we would have a Manhattan Project to address this, and that's what we should do in our country. Of those who screened positive, 70% were in need of a brief intervention, 14% brief treatment, which meant repetition up to 6 times of the message, and 16% required a referral to treatment. And then we looked at the outcome measures, and there were reductions across the board in terms of specific drugs, heavy alcohol use, changes in functional domains as well. So within a few months, I decided to analyze what kind of incentives we could provide through the White House for translation to scale. The first thing I did was travel to the American Medical Association headquarters in Chicago, and they were mildly but certainly not deeply committed to alcohol and drug addiction. This was not a core focus of the medical community. And so I said, yes, but prescription drug abuse is highly correlated with abuse of alcohol and other drugs. And the ears perked up. And from that came an invitation to come to the CPT board, the billing code meeting that was held in October. I looked at the cost effectiveness data. Who will benefit if we implement this type of program? I looked at the billing codes. That was the key. If there were no billing codes, nobody would do it. And that was, from my point of view, one of the most important things. Other financial incentives, training, federal government programs, I can go through all of these, but we don't have time. So how do we catalyze change? The bully pulpit, multiple grand rounds, multiple presentations in front of every single national organization, targeted meetings with the American Hospital Association, America's Health Insurance Plan group, the American Committee, the American College of Surgeons. The invitation to the White House had some impact. And then national leadership conferences on medical education bring the leaders of medical education in, and including putting some federal funds to it, including developing a number of of partnerships with the public and private sector, including the ACCME, which developed continuing medical education courses gratis for us, and the scientific data. What was accomplished? We got the CPT codes, the Medicaid and Medicare codes. I called every state Medicaid director in the country twice, sent letters twice, including with the AMA letterhead, because they, at this point, were very focused on it. The Office of Personnel and Management, OMP, which decides on health care plans for all federal employees, which are over 6 million, and asks them to put the codes in their call letter, which goes out to over 250 health care insurers. And after severe arm twisting, they agreed to do it. Severe is an understatement. And then CMS, again, multiple phone calls, sometimes 4 times a day, to the head of CMS to put a set-aside into their line items for SBIRT code reimbursement. The VA, and we can go on and on, it's not important to summarize all of these, but this is what happened during this period. The subsequent legacy was that the National Drug Control Strategy is highlighted SBIRT as a key component of the strategy. Medicare will now cover annual alcohol misuse screening by beneficiaries' primary care provider, and at present, SBIRT research, training, and support is rapidly gaining momentum in healthcare programs nationwide. I would just like to close with treatment needs. We know that this treatment needs will expand because SBIRT will identify millions of people in need of treatment. There's increasing drug use, the policy decisions, the legalization movement, reduced criminal penalties, increased focus on drug courts, all leads to increased needs for treatment. The Medicare costs are higher in patients with substance use disorders. Insurance has expanded for children to age 26. This is the population at highest risk for substance abuse, and of course, mental health parity and workplace inefficiency. I won't get into this comparison of principles, evidence-based principles of treatment and the practice of the 14,000 treatment centers in the country, but I did a side-by-side comparison for a NIDA Council committee that we organized to help understand why evidence-based is not translated. I'd just like to close by saying this is not a war on drugs. This is a defense of our brains. The brain is the source of our humanity, and that is my philosophy, and that is what drove me into this position and drove me during service. Thank you.